Hi, I'm David Cloud with Amend at the University of California, San Francisco. Amend is a program that works to promote the health and the wellness of people who live and work in jails and prisons across the United States. Welcome to this brief presentation where we will clearly distinguish the differences between solitary confinement and the ethical use of medical isolation and quarantine in response to the COVID-19 pandemic. This presentation is intended for corrections officials, policymakers, healthcare professionals, advocates, or anyone who's committed to halting the use of solitary confinement in our jails and prisons across the United States. So the COVID-19 pandemic poses unprecedented challenges to everyone working to end the use of solitary confinement in U.S. jails and prisons. Most of you know by now that jails and prisons are epicenters of COVID-19 outbreaks for a number of reasons. First, in the age of mass incarceration, jails and prisons are crowded and densely populated spaces where adhering to practices such as social distancing are inherently difficult, if not impossible. Access to sanitizer, hand soap, and other materials necessary for personal hygiene and disinfecting living quarters are often hard to come by or labeled as contraband. A large number of jails and prisons hold people who are particularly vulnerable to severe illness or death from COVID-19. These include older adults and those with underlying chronic medical conditions, which we know are disproportionately prevalent in jails and prisons. Over the course of the COVID-19 pandemic, many incarcerated people will require temporary and humane quarantine or medical isolation to undergo monitoring, treatment, and triage to stem the transmission of the virus. In this context, it is critical to distinguish clearly between solitary confinement, medical isolation, and quarantine so that we all have a common language and vision for appropriate medical responses to outbreaks in jails and prisons. Clarifying the components of medically ethical, humane, and effective approaches for protecting the health and safety of incarcerated people is a pressing need, and it demands focused collaboration between public health professionals, healthcare providers, corrections agencies, and the advocacy community. We hope that you find this presentation useful. So let's start with some definitions. Most of us know that solitary confinement is the practice of isolating people from the rest of the general population. It's a form of punishment that involves imposing punitive measures such as major restrictions on visitation and phone calls from family and loved ones, restrictions on recreation and time out of cell, deprivation of access to rehabilitative and educational programming, and severe restrictions on access to personal property. Solitary confinement can last anywhere from days to decades. The decision of when it ends rests in the hand of security staff and correctional officers, and in some jurisdiction, policy dictates that solitary confinement can last indefinitely. So why will solitary confinement worsen the COVID-19 crisis? One of the most important things for preventing and mitigating the spread of COVID-19 in any setting is for people experiencing symptoms to report them immediately. This requires trust and an understanding of what's going on and what will happen if people disclose their health status. Solitary confinement is a form of trauma. It's a practice that's known to contribute to excess morbidity and mortality among currently and formerly incarcerated people. We know that exposing people to solitary causes immense psychological suffering, lasting trauma, and too often results in self-harm, violence, and suicide. Fear of punishment is toxic for public health prevention. We see it with other infectious diseases, and this is no different. If people fear that they're going to be placed in solitary confinement, then we should certainly expect that they'll be less likely to report any symptoms to nurses, correctional officers, or any other staff that may be able to help them receive treatment and implement the most effective strategies. We're hearing stories across the country that jails and prisons are turning to solitary confinement units for medical isolation. This is not surprising given what we know about the architecture of jails and prisons, since these are often the only places where it is possible to separate people. However, we must be mindful that many units may not be equipped for medical isolation. We'll explain why later, but it's important to remember that if an institution is not equipped to do this ethically, then they must consider other alternatives. So now I'll provide some definitions of quarantine and medical isolation. At Amend, we've tried to give some guidance on and lay out what this should look like in a jail or prison, recognizing that doing so is inherently challenging in places that were designed for punishment. So let's start with quarantine. What is quarantine? Quarantine is the practice of separating or restricting the movement of people who may have been exposed to a contagious disease until it can be determined if the individual will become ill from the disease. It's keeping people in place until it can be determined whether or not they become sick. A lot of healthcare professionals treating patients with COVID are in quarantine from their families. In the community, quarantines when people remain at home or another location to prevent further spread of illness to others and to carefully monitor for the disease. In a jail or a prison, quarantine is being used as a justification for keeping people confined to their housing units. That's whether it's a dorm, a bunk, or a cell. A point that I will make over and over again is that having the capacity to test people for COVID is absolutely critical to being able to implement quarantine and medical isolation effectively. So once a person's in quarantine, medical staff need to assess each person to determine whether they have COVID. Ideally, this is done with a diagnostic test that's sent to a lab. Most tests are nasal swabs that have been sent to the laboratory for results. Results could take hours or days. It really just depends on the lab capacity. If testing is not available, which we know there's a national shortage and even bigger shortage in jails and prisons, then it may be necessary for medical staff to assess symptoms of COVID-19 while the person is in quarantine. So in this event, they'd be looking for a cough, fever, shortness of breath. But the challenge here is that a lot of people with COVID experience very mild symptoms, so it makes this non-test-based strategy very difficult to do. But we do know that on average, it takes about 5 days from exposure to the coronavirus to the onset of symptoms. But nearly everyone exposed will show symptoms or test positive after about 12 days. This is known as the incubation period. It's also important to remember that quarantine is a clinical practice and should not be punitive by definition. So what is medical isolation? Medical isolation is different than quarantine. It involves isolating a person who is known to have a contagious disease, here COVID, until a doctor determines that the person has recovered and is no longer contagious to other people. Depending on the situation, people infected with COVID can be medically isolated alone or together with other people who are also infected. Again, if done ethically, medical isolation is a clinical practice and should not be punishment by definition. So we created this Venn diagram to illustrate the point that solitary confinement is very different from medical isolation if done ethically. In fact, the only thing that solitary confinement and medical isolation share in common is the separation of people from the general population. So now let's discuss some of the conditions for ethical medical isolation and quarantine to clearly distinguish it from solitary confinement. Remember, medical isolation is for people who have COVID-19, so oftentimes these people can be housed together as long as they're isolated from the rest of the population, and as long as they're not housed with people who do not have COVID-19. Quarantine is for people who have been exposed to COVID-19. We do not know if they have it or not yet. So people in quarantine will have to be housed alone. We don't want them to be housed with people in medical isolation who have COVID-19 because they might not have it, and we don't want them housed in the general population since they might have COVID-19. So what are the conditions for ethical medical isolation and quarantine? First, the care and conditions for anyone placed in medical isolation or quarantine should be overseen by a medical professional, not security staff. This is a time where health trumps security, and wardens and other corrections officials need to understand and fully embrace that. Medical directors and lead nurses need to be empowered to make decisions, and they should also be responsible for making sure that people are treated humanely. Second, there must be at least daily visits from healthcare and mental health care staff. Clinical staff should have an enhanced presence in any housing unit where people are held in medical isolation or quarantine. That means walking the tiers and doing check-ins at the cell door are not enough. Next, there has to be clear and daily communication. People need to know why they're placed on quarantine or medical isolation, receive updates on their health status, and be provided accurate information of when they can expect to be released. This is a very scary disease, and honest and frequent communication are fundamentally important. Since a lot of people have relatively mild symptoms, there's no reason that people should be blanketly excluded from going outside, getting sunlight, or going for a walk if they feel up for it, as long as they're not recreating with people who do not have COVID-19. COVID-19. There should be enhanced access to TV, tablets, and reading materials. Being on medical isolation or in quarantine sucks anywhere, but especially in jail or prison. Corrections officials should go out of their way to make this experience as bearable as possible. There must be unfettered ability to communicate with loved ones. I've been following anecdotes from Solitary Watch, and it's heartbreaking to read about people who have been isolated with no way to talk to their families. Doctors and corrections officials have a duty to communicate with families and to let their patients do the same thing, and it should not cost them a penny. It is not ethical to use a restrictive housing unit for medical isolation that does not have proper ventilation and sanitary conditions. This disease is transmitted by transfer of droplets. So that leads us to worry a lot about a unit that has big industrial fans or units that are dank or damp, especially as the warmer weather approaches. Without proper ventilation, there is some risk this disease could be transmitted. There must be transparency and coordination with public health departments. This means that corrections agencies are doing the best to keep track of how many people are in medical isolation and quarantine, how long are they staying there, and when are they released. The setting must be fully stocked with medical supplies for treatment of patients and to ensure the safety of staff. Anyone in medical isolation or quarantine should be provided regular and nutritious meals. There is no excuse for people to receive alternative foods that they might otherwise receive if placed in a solitary confinement unit. So when can a person be released from quarantine? It can vary, but once the incubation period, generally about 14 days, is finished, one of two things should happen. If they test positive, then they should be moved to medical isolation. If they do not have COVID-19, then they should be able to go back to the population or back to the housing area where they came from. So when can a person be released from medical isolation? The CDC has guidelines that should be followed and govern length of stay in medical isolation. This is not solitary confinement, so the rules on reviewing people that normally apply, those must go out the window. By definition, medical isolation ends when there's medical evidence to confirm that a person is no longer infectious to other people. So there are two ways to determine if a person is no longer infectious, and this again hinges on whether or not testing is available. These factors are changing as scientists' knowledge of COVID-19 grows, but in a nutshell, there are test-based and non-test-based strategies. Again, these factors are in flux, so it's critical that any correctional facilities keep up to date with the most recent infectious disease guidelines from the CDC and state and local health agencies. There are two different strategies that are used to decide when to discontinue medical isolation. The first is a test-based strategy. Implementing this strategy hinges on the ability to have access to testing kits. We know this has been a challenge in many correctional institutions. So people who have symptoms and test positive may discontinue isolation under the following conditions. Their fever resolves without using Tylenol or any other fever-reducing medication. Their respiratory symptoms improve, and they've tested negatively consecutively twice with swab tests collected 24 hours apart. For facilities that don't have testing available to them, there is another procedure that can be used to make a decision to discontinue medical isolation. This applies to people who have symptoms but were not tested, and the three conditions must be met. At least 3 days should have passed since recovery, which here is defined as having no fever without the use of Tylenol or other fever-reducing medications. Respiratory symptoms must be improved, and at least 7 days should have passed since the symptoms first appeared. So there are a number of things that departments of corrections must do in order to implement medical isolation and quarantine procedures ethically. First and foremost, they should use the conditions that we've outlined in this presentation to make sure that each of those conditions are met. Next, they must communicate with residents. It's unacceptable to just impose lockdowns or move people to solitary confinement units against their will and not provide a clear and compassionate rationale for moving people. Departments of corrections need to empower healthcare staff to do the communicating. The message should not just come from line officers. They should be informed, but they should not be the stewards of communication. Next, departments of correction should reach out to health departments to request testing kits. Without testing capacity, it is honestly going to be very difficult to practice honest communication, build trust, or implement medical isolation or quarantine procedures in an ethical and appropriate manner. Next, there needs to be transparent tracking and reporting. DOCs need to be tracking how many people have suspected and confirmed cases. They need to document the supplies they are using any shortages they have, and how they are using quarantine and medical isolation. If they do this, it puts them in a better position to advocate for additional resources that they don't have. Transparency around this information helps the larger external community with surge planning. Departments of Correction must be honest and transparent if the housing units they're attempting to use for medical isolation cannot be operationalized to implement those procedures ethically. In that event, they must be open to transferring people from medical isolation in the community and reaching out to governors, public health agencies, parole boards, or other power brokers who can help ensure that people can be released to undergo medical isolation outside the walls of the prison or jail if that is necessary. So first of all, public health agencies have an ethical duty to assess the capacities for medical isolation in jails or prisons. In any outbreak situation involving an infectious disease, public health is a discipline that is expected to mobilize and deploy resources to hotspot areas. We see this with HIV in the context of the opioid epidemic. You expect public health agencies on the ground figuring out how to contain the spread of a disease. It's been quite unnerving the absence of discussion of jails and prisons as epicenters of the COVID-19 pandemic. But this is no different. So what we should be doing is calling on our public health systems to show up at jails and prisons, take a look at what's going on, and be part of the plan. They have an ethical duty to protect the people who live and work in these settings. So public health agencies show up and take a look at what's going on. They should also be allocating testing, medical supplies, anything else that these facilities need to do to ensure that isolation and quarantine practices are done ethically. Public health agencies should be taking a look around their communities, asking questions like, where are people getting tested? Where are the drive-up testing operations? Who's making those decisions? And whoever is making those decisions, you need to get them educated and informed on what's going on in the jails and prisons and get those testing protocols inside the walls. Additionally, it's our hope that more health departments will issue emergency guidelines that clearly explain the components of implementing medical isolation in accordance with ethical guidelines for jails and prisons. They can find guidance here and also at the World Health Organization and the CDC for further guidance. But really, the elephant in the room with all of this is the need to get more people out of jail and prison. Everything that I've outlined so far is contingent on having fewer people boxed in together. Public health officials, whether in health departments or if there's a leading academic who the public trusts, they need to be pushing for depopulation urgently. So public health systems should also be accountable for accepting patients from jails and prisons for medical isolation, either in hospitals or other community settings that have been set up to do so. The bottom line is that people who are incarcerated should not be excluded from going to medical isolation outside the walls. So here are a few things that advocates can do. First, we hope that they have a clear messaging to distinguish differences between medical isolation and solitary confinement. Understanding the different components of implementing medical isolation ethically will help them focus in on the specific things they should be fighting for during this emergency. We ask that advocates call on health departments, government task force, and others that control the distribution of COVID-19 resources. They should call on these entities to ensure that enough testing kits, equipment, and staff are deployed to jails and prisons to ensure these policies are implemented appropriately. Advocates should also focus on the shared health hazards for employees and incarcerated people in their advocacy. Finally, we must reiterate that releasing as many people as possible from custody in the midst of this pandemic should be our public health priority number one. Doing so is necessary for a host of reasons. It will mitigate infections and save lives of not just incarcerated people, but also correctional workforces in the surrounding community. With too many people in crowded spaces, it's not possible to do effective social distancing. Releasing people also relieves strains on overstretched correctional healthcare systems that are on the front lines of this pandemic. And lastly, it ensures that medical isolation and quarantine practices are implemented ethically for individuals who remain in custody. We've put together a bunch of different COVID-19 resources that amend. You can find each of them here, and please feel free to reach out and contact us for additional guidance. Thank you, and please stay well.